Good afternoon. My name is Beth Feynman, and I'm joined by Dr. Joseph Terriman, Sandra Rome, and Kim Noonan, and we are here to discuss case studies for nurses, the evolution in myeloma treatment. This meeting space has been assigned to provide a symposium supported by the International Myeloma Foundation during the Oncology Nursing Society's 44th Annual Congress. The Oncology Nursing Society's assignment of meeting space does not imply product endorsement. The Annenberg Center for Health Sciences at Eisenhower is accredited as a provider of continuing nursing education, so don't forget to fill out your sheets at the end of the event to evaluate us, because you will receive a maximum of 1.5 contact hours earned for the successful completion of the activity. This slide here is a disclosure of conflicts of interest. It is the policy of Annenberg to disclose any conflicts of interest, and our conflicts of interest are printed in the bulletin. Print names, demographics, and identifying information on the case studies that will be presented have been masked to maintain HIPAA compliance. So there's no real persons have been used in the development of these case studies. Off-label use of drugs may also be discussed. Now, we have slides available for download at www.imfons.myeloma.org, as listed here. They may be live at this time, so you can check back during this presentation. Otherwise, feel free to go and download them after this symposium. Evaluations with CNE credit are enclosed in the packet along with the guidebook. So this packet is on the chair that you were sitting down on, so use those packets. As I mentioned before, my name is Beth Feynman. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I'm joined by Dr. Joseph Terriman from DePaul University. Additional faculty are including Sandra Rome from Cedars-Sinai, right here in Cali, and Kim Noonan, who flew across the country from the Dana-Farber Cancer Institute. And Kim just acquired her doctorate of nursing practice, so let's congratulate Kim. We are all members of the International Myeloma Foundation Nurse Leadership Board. We are pleased to have other members of the Nurse Leadership Board in the audience that are enjoying this symposium today, as well as you are too. We want to thank you all in the audience, as well as our additional members, for joining us. The International Myeloma Foundation is dedicated in improving the quality of life of patients who are working towards the prevention of cure and prevention of myeloma. The International Myeloma Working Group, Black Swan Research Projects, as well as additional publications are all available at your fingertips at any time. You can go to www.myeloma.org, or actually we have a big packet of information available for you. You can see on this slide all these pictures of publications, CE credit, and I wanted to highlight this is our program brochure, which has our faculty information and disclosures, and on top is this is not a bottle opener, it's a fancy new key fob that, or USB point. I thought it would be a bottle opener. I said, thanks IMF for my new bottle opener. But it's actually a USB for you to download. And it takes hundreds of hours to compile all the guidelines for diagnosis and management of myeloma. The Nurse Leadership Board has published numerous peer-reviewed documents, as well as patient materials, patient tip sheets, side effect management, etc. So please do not throw these away or leave them in your hotel room. Take them home and share them with your friends. The agenda is listed on this slide here. We are going to be going through a series of case studies to highlight the importance of diagnosis and management of myeloma. And as a result of this program, you will be able to identify common treatment regimens in newly diagnosed multiple myeloma, discuss nursing management of myeloma patients receiving these newer therapies that are all available, identify the steps in shared decision-making. This is a big initiative, the Institute of Medicine, as well as other parts of oncology, and discuss the importance of survivorship care plans. On top of that packet that you have received is an ARS keypad. Part of our outcomes, we'd like to ask just a couple of pre and post questions. It's required for the symposium, and so if you don't mind taking a break from your salad, would you please answer the question, which of the following is used for diagnosis of myeloma-related organ dysfunction? 1, fluorescent in situ hybridization, or FISH. 2, monoclonal gammopathy of unknown significance, or MGUS. 3, spinal cord compression, albumin level, presence of lytic lesions and total protein level, SALT. Or 4, calcium level, renal status, anemia, and bone lesions, CRAB. See lots of acronyms today. And we will be sharing the correct answers throughout the presentation, and then you'll have a post question as well. Next question, which element is essential to foster shared decision making? Greet your patient, seek your patient's participation, sharing information by both parties, or 4, building consensus about preferred treatment by both parties. After Dr. Terriman's presentation, you'll confidently pick the right answer. Now all of them sound good to me, right?
This will be an important take-home message.
Good. Number 3, which of the following is true about newly diagnosed patients with myeloma? Number 1, all patients should be tested for MRD as soon as possible. Number 2, shared decision-making is only effective if the doctor and patient discuss treatment options. 3, all patients need to be educated on many topics, including bone health, renal health, and infection prevention. Or 4, bone strengthening agents are only recommended for patients with bone damage from myeloma. And last but not least, which of the following is an all-oral regimen for relapsed multiple myeloma? Number 1, KRD, 2, IRD, 3, EPD, 4, DPD. And so this is the first day of Congress. Imagine how you're going to feel on the last day with all the disease states you're going to be reviewing. So at this time, again, I'd like to thank you for your kind participation. I hope you enjoy the program that we're beginning to deliver. And I would like to turn the podium over to Dr. Joseph Terriman, who will begin with the background of shared decision making.
All right, well, good afternoon, everyone. And I would like to only mention my manager, Paula Inches from Northwest Oncology Hematology is here, and my colleagues. I practice every Wednesday at Northwest Oncology Hematology. Thank you for coming, and welcome, everyone. Let's start with an overview of multiple myeloma. Multiple myeloma is a cancer of the plasma cells, and these 2 words are not common terminologies that patients often understand. We always have to go back to the basics, and we have to inform the patient that plasma cells originate from the B cells, and they are stimulated by an antigen. So when someone sneezes on you with an antigen, it will stimulate the body, the B cells particularly, to produce the plasma cells. And then the plasma cells will produce the immunoglobulins, the normal healthy immunoglobulins known as the GAMDE or GAMD. Myeloma cells, what happened in multiple myeloma is that because it is a monoclonal proliferation of plasma cells, it will only produce one type of the immunoglobulin. So instead of having a polyclonal response, multiple myeloma produces monoclonal response, and it's very typical that you will see in a multiple myeloma patient that one of these immunoglobulins are elevated. The most common multiple myeloma is the IgG, followed by IgA. So you will typically see an elevation of one of these immunoglobulins. And then, in part of the diagnostic workup for multiple myeloma, we are going to measure the level of the immunoglobulin that's produced by the multiple myeloma cells using serum protein electrophoresis for the heavy chain and urine electrophoresis for the light chain. Typically, if a patient has an IgG, the monoclonal protein will migrate in the gamma region, but for the IgA subtype, it will migrate into the beta region. So please pay attention to the laboratory result. This right now is showing that the protein is migrating into the beta region. This is typically seen in an IgA subtype. Whereas if the myeloma is an IgG subtype, you will typically see the spike happening in the gamma region, and that's your IgG multiple myeloma subtype.
In terms of multiple myeloma, not everybody with an abnormal paraprotein in their blood or urine actually needs treatment. So in my practice, I see patients with newly diagnosed extra protein in their blood or the urine. So they come to me thinking, what do I have? So I go through the different steps of diagnosis. So the first level is MGUS, monoclonal gammopathy of unknown significance. Those individuals have a little bit of extra paraprotein in the blood or urine. They may or may not have any anemia or kidney problems, but we definitely look for them to have a low amount of protein in the bone marrow plasma cells as well. If you go into the second level, is smoldering myeloma, where they have a higher paraprotein with an M spike about 1.5 to 2 grams, a little bit extra free light chain ratio. Again, when Dr. Tierman mentioned the M spike, there's also a serum free light chain where the light chains can fly off the immunoglobulin structure. And so in olden days, those used to be our non-secreting patients where they didn't make a lot of protein in the blood. So free light chain ratio is very important to the myeloma diagnosis as well when the light chains are high. Patients are catapulted into an active myeloma phase when they have a high amount of paraprotein in the blood or urine and they have CRAB criteria: hypercalcemia, renal insufficiency, anemia, or bone disease that can be attributed to the paraprotein. So as you can see, it's generally 3 levels, but within those levels, we looked at risks. So who's at high risk or low risk of needing treatment? The great thing about managing myeloma in this day and age is we have a number of excellent therapies. From 1960 to 2000, there wasn't much in the way of effective treatments. But since 2000, we've had an explosion of new therapies. We have classes of drugs: bortezomib, carfilzomib, and ixazomib. Those are your proteasome inhibitors. We have immunomodulatory drugs: lenalidomide, pomalidomide, and thalidomide. And then we also have monoclonal antibodies: daratumumab. Denosumab is a supportive care drug, but it's effective in decreasing skeletal events in patients with myeloma. So while many patients have this MGUS, they go about life with their normal health care conditions, and then ultimately something happens. The DNA in those cells change, and then it makes a clone of a normal protein, as Dr. Tierman mentioned. So that overproduction will lead to active myeloma. Some patients will live in that active myeloma phase. They'll go into remission. But unfortunately, through a series of remissions and relapses, they may ultimately become refractory as the clones will change over time. But the good news is that myeloma patients are living longer than ever. This is a study that looked at the different groups of patients from 2006, 2008, and 2010, and we saw a probability of living for over 8 years at least, if not longer. The good thing is now in the era of these newer agents, it's 2019, we don't know how long a newly diagnosed patient will live, likely for many, many years, as myeloma is turning to be a chronic condition.
And given the plethora of treatment for patients with multiple myelomas, you can see, when I started practicing multiple myeloma way back in 2001, there were only a few treatments. Now we have over 15 novel agents now that we can use for patients with multiple myeloma. This gives us the perfect storm to really embrace patient-centered care, or what we call preference-sensitive treatment decision-making, using the shared decision-making model. The shared decision-making model is a healthcare delivery system model that includes the patient's preferences, values, and choices, putting the context of the patient into their lives while they are getting the treatment. It is very well aligned with the Institute of Medicine's guidance to improve healthcare and also their vision of the 21st century healthcare of the United States of America. And it's also embedded in the Affordable Health Care Act in 2010. So what is shared decision-making? Well, the definition of shared decision-making was really a breakthrough landmark publication by Whelan Gaffney, and they have defined shared decision-making having 4 elements. The first element is that it has 2 participants, the clinician and the patient. The second element is that both parties need to exchange information. And the third element is that both parties take steps to build a consensus. So this is an ongoing process. This is not static, and that this is really ongoing. And then the last step is that there will be a mutual agreement that will be reached between the clinician and the patient. This is the hardest part of the shared decision-making model. When it comes to the implementation of shared decision-making model, the mutual agreement should be explicit. A lot of times, this is implicit. We think that because the patient said, and then patients nod, that they already took the treatment and that's it. You go to the infusion center and you start your treatment. That needs to be more explicit, and one way of doing that is really to ask the patients, can you tell me more about what you understood about the treatment and when do you think you are going to start the treatment? Those are some kind of validation that we can really say we're able to have an explicit agreement of the treatment decisions. The Agency for Healthcare Research and Quality, AHRQ, also really tried to help a lot of the clinicians in the implementation of shared decision-making model by putting through the 5-step process called SHARE. In this process, what the Agency for Healthcare Research and Quality really emphasizes step number 1, and that is you need to seek your patient's participation. And how do we do this? Very simple. Right at the very beginning, we need to say to the patient, at this moment, your situation has 2 or more viable, equal treatment options, and I would like you to participate in the treatment decision making. Your preferences and your personal values matters the most at this moment. So this is very important, according to the Agency for Healthcare Research and Quality. After that, you can help your patient explore and compare treatment options. Make sure that you help the patient find the right information, guide them to the correct websites, give them some pamphlets from the International Myeloma Foundation, give them a lot of informations that are non-biased. And again, this is your way of making sure that the patient gets the information. Assess the patient's values and preferences. This is very important. What matters the most to the patient? Are they having an occasion? Are they gonna have a wedding? Are they going to have a graduation coming up? And are all these things that the patient's still trying to achieve embedded into the goals of the treatment? And then number 4 is to reach a decision with your patient. And lastly, always evaluate your patient's decision, because this is not a static process. This is always ongoing. You always need to revisit the decision of the patient. And here are some of the examples of what I call the clinical pearls that we can say to our patients. For example, for step 1, again, as I've mentioned, you need to explicitly say there are 2 or more treatment options for your condition. One is X and one is Y. And the benefit and the risk for X is this, and the benefit and risk for the Y is this. And how does that affect your situation? How would that affect your employment status? How would that affect the context of your day-to-day lives? The other exemplar is, hearing what I just told you, are there any thoughts, concerns, or worries that immediately come to mind? By saying this, immediately the patient may say, oh my God, I really can't do that because there's a wedding that's coming up, and if this treatment is going to require me to be in the clinic twice a week, that would be very disruptive to my schedule. So it's really important that the patient will provide their feedback immediately by asking them some of the feedback or immediate thoughts or concern as soon as the treatment is discussed. The word together is always a very powerful word that we can always share to our patient. Try to always use the word together in your conversation with your patient, just like this. We can make a decision together now, but you might also prefer to have some time to think about things or talk to others and make it on your own or with your family. This allows the patient what we call the option talk, which allows the patient to have a deliberation process and then make a follow-up appointment for the decision talk. And this is really important so that we can definitely have a very good implementation of what shared decision-making should be. So these are the 3 nursing role that we have identified in the literature in terms of what is it, if we delineate our role as nurses, what is it that we can do as nurses in the shared decision-making process? We thought that these 3 are the most important role. Number 1 is to empower the patient. And by saying there are many different ways to treat multiple myeloma, the doctor will be in shortly to discuss these with you, but since each of them have pros and cons, it is important to discuss what is important to you. if the patient asks you, if you are me, what would you do? The answer is always, I will always do what's best for me. So always give it back to the patient. Never, ever, ever go with the temptation that you're going to say something about yourself. Always empower the patient that it's about the patient. Inform the patient. Provide them with all the necessary pamphlets, educational booklets. You can also refer them to the NCI website. It has a lot of information. The NCCN website also have a lot of information about multiple myeloma and treatment options. And the third, but not the least, is to advocate for the patient. This is the third most important role that the nurse can do in shared decision-making. The exemplars that Mrs. Z said, she'd like some time to consider her options. Can I give her a myeloma booklet and schedule a return visit in a few days after she talks with her family? Or a statement something like this, Mrs. Z expressed concern about, is there something that we could do? So these are the kinds of exemplars that we can really show that we are advocating for the patient. That means we are putting our shoes in the patient's and we are doing the best that we can for the best decision for the patient. So this is the final slides that I'd like to share with you. It is important that patients and clinicians are educated about shared decision-making. This is a concept that's been around for quite some time, at least a decade. In fact, there's already a systematic review about shared decision-making. And that what we found from that systematic review was that it is important that we educate both the patient and the clinician on what shared decision-making is all about. My research is already completed, and we have developed successfully at DePaul the competency scale for the role of the nurse in shared decision-making, and it's going to be able to really identify the areas that needs to be strengthened when it comes to the competency of the nurse in shared decision-making. There's a lot more work to do, but never ever be paralyzed by all these limitations. Just move forward. Thank you.
You're not done yet. Stay up there. I still have more slides. Dr. Terman is so passionate about his research, and that's why we put it in the beginning, because it's so important to our myeloma patients. In many cases, as I mentioned, there are different levels. And that smoldering level, people that don't quite have myeloma yet, we have to find ways to treat them before they have organ damage. Options for high-risk smoldering myeloma, those ones that we can predict might need treatment in the next 1 to 2 years based on bone marrow plasma cells, PET or CT scans, those are ones that need a lot of our guidance and counseling. The International Myeloma Foundation has a lot of information. There are 4 major phase 2 clinical trials. 3 of them have lenalidomide as a backbone, which is a pill. And each of these clinical trials with ixazomib Lendex, elotuzumab Lendex, carfilzomib Lendex, and just plain old daratumumab, each of these show that it might be beneficial to patients to start treating later. Updates as smoldering treatment paradigms are evolving, but this might be something we are going to be talking more about. If you have a patient in your clinic that has a lot of protein in their blood or urine and they're not quite fitting that CRAB criteria requiring treatment, direct them to the myeloma.org website. They have a myeloma matrix that outlines clinical trials that are open in their area. They have an IMF info line at 800-452-CURE, and you can direct them there for more resources. Thank you, Dr. Terman, for presenting on shared decision-making. I'd like to invite Ms. Sandra Rome to share us our first case study, Mary.
Thank you. So we have several case studies that we're going to talk about in terms of the trajectory of our multiple myeloma patients being treated. Mary is a 66-year-old retired librarian. She's married. She was active and generally in good health. In November of 2018, she presented to the ED with severe back pain. An X-ray showed a fracture of a spinal cord compression at the T1, and you can see that in that picture there. Also other lytic lesions, and her creatinine was elevated. So how do myeloma patients typically present? Well, you can see at the top, oftentimes, such as in Mary's situation, they come to the ED with a severe back pain and often spinal fractures and maybe some renal failure, abnormal labs, etc. Some non-emergency presentations might include they visit for a specific complaint, maybe they just have had this low back pain for a while, abnormal test results, maybe their creatinine is elevated, etc. Or maybe just on a routine physical exam, patient with few to no symptoms, maybe they see an increase protein in their urine, etc. So both of these situations, of course, we have to take care of the emergent problem, but with a non-emergent presentation, there's a little bit more time for some shared decision-making. So Mary presented with that horrible, painful bone lesion, and as we know, that can be an emergency when you're thinking about an impending spinal cord compression. Of course, if there's a solid plasma mass, that can be locally irradiated either in the spine or in other bony parts. Generally, though, if you have a lytic lesion where the bone really has a space in it, you need to fill that space. And so we have options such as vertebroplasty, where bone cement is injected to stabilize the spine, or kyphoplasty, which uses a special balloon to create a space within the vertebra, and then bone cement is placed, and that restores the height to the vertebral body. Orthopedic surgery also may be used to pin a long bone if that is needed. So the diagnostic workup for multiple myeloma, Joseph and Beth talked a little bit about this, but of course we have many lab tests, so they're looking at that serum protein electrophoresis. They might look in the urine for also those abnormal proteins. They're going to do a CBC and differential and chemistry, and they're going to look at the albumin to see if it's high or low, and they're going to look at these non-specific inflammatory markers, beta-2 microglobulin and LDH. They're going to look at the free light chain ratio of the kappa and lambda light chains that we talked about, and a monoclonal protein analysis to see what abnormal protein is presenting. And you can see again that spike on the SPEP there. Of course, a definitive diagnosis is by the bone marrow biopsy, and with that, they're going to do FISH testing, cytogenetics to see if they have some high-risk features, maybe some gene expression profiling, and maybe some plasma cell studies that look at sort of the virility of how fast the myeloma cells are growing. And then, of course, imaging studies. So as we saw with Mary, a lot of times the first diagnostic test might be a typical skeletal X-ray. And those really, in terms of screening for significant bone disease, are not really the standard once you've thought about that the patient has myeloma. So a whole body low-dose CT scan is the best for early screening for bone disease. A PET CT scan might be done for a response assessment, active residual disease, and then a whole body MRI of the spine and pelvis. That's sort of the gold standard to assess for further bone marrow involvement. DEXA scans really are not useful unless, of course, you're working somebody off for additional osteoporosis. So then the patients need to be staged, and this might look a little busy, but it's easiest if you look at their stage 1, at the bottom there's stage 3, and what's not stage 1 or 3 is stage 2. So stage 1, you can see, and this was actually based on thousands of patients, and they looked at, okay, what variables are the most important in terms of looking at 5-year overall survival and 5-year progression-free survival. And what they found was it was these sort of nonspecific markers like serum beta-2 microglobulin. If it's low, if they maintain their serum albumin, so that is fine. If they have no high-risk cytogenetic features and their serum LDH is below the upper limit, which is about 250, 260 for a lot of institutions. So those patients would be stage 1 with an 82% 5-year overall survival and a 5-year progression-free for survival. Stage 3, on the other hand, is with an elevated serum beta-2 microglobulin, high-risk cytogenetic features such as deletion 17p or translocation 14-4, and or a high serum LDH. And you can see the 5-year and progression-free survival were much higher in those patients. And then, as I said, stage 2 is in between those two. So let's get back to Mary. So Mary, of course, she had her peripheral blood drawn. Her calcium is actually fine. Her albumin was a little bit low of 3.3. Her beta-2 microglobulin was actually a little elevated, 5.3. Her LDH was actually not elevated significantly. Her creatinine, however, was 2.1, and her GFR was also reduced. Her hemoglobin was a bit low at 10.8, and she did have kappa light chains on her peripheral smear, and her kappa lambda ratio was significant as well. Of course, the bone marrow biopsy showed she had 60% plasma cells that were kappa, and her cytogenetics showed that they were normal. She didn't have any of those nasty cytogenetic markers that we look for. Her whole body low-dose CT showed that she did have additional lytic lesions in her arms, ribs, skull, and femur, and so she was diagnosed with active myeloma, revised International Staging System, stage 2. So now that we have some time with the patient to talk again with that shared decision making, there are so many options for our patients. And so, and you're going to hear throughout our talk here how, the treatments can change over time. They're very patient individualized, and really staying on treatment, not that there can't be some sort of rest in between, but really staying on treatment is paramount for the survival of these patients. So you can see on the left front line, there's a whole smattering of options for patients. If the patient is frail or very elderly, maybe they got some renal problems, all those things are taken into consideration, and maybe they're going to recommend a 2-dose regimen, such as bortezomib and dex or lenalidomide and dex. For patients that are a little bit more robust, and again, this is not necessarily age-related treatment, they may recommend, or through the shared decision-making process, decide on a 3-drug regimen, so bortezomib, len, and dex, or carfilzomib, len, and dex, and then some newer therapy regimens, combinations such as bortezomib, melphalan, and daratumumab, so a 4-drug regimen. And then, of course, autologous stem cell transplant is an option for many patients. And then, of course, there's maintenance. We're going to talk a little bit about that later. And then there are all sorts of options at relapse, so ixazomib, pomalidomide, daratumumab, a variety of agents that are often in combination as well. And then throughout the trajectory, patients may consider new clinical trials, and there are always those that are available, and Beth mentioned some great websites to help your patients and their clinicians share that decision.
And I know that I think of things in buckets as well, as Sandra just described all of those drugs. Imagine how your patients feel at diagnosis. They're sometimes like a deer in a headlight. So directing them to the IMF where resources are available and educating yourself through symposiums like this are very important to help them make the decisions that are best for them. The autologous stem cell transplant procedure remains a common standard of care for many individuals in the United States of those who are transplant eligible. So who's a transplant candidate? Why would one person get a transplant versus another? It focuses on desire, age, comorbid conditions, do you have a caregiver? Financial status is also factoring in. But we know that patients up to age 75 can be considered for a stem cell transplant, and it's generally within the first 4 to 6 cycles of any induction treatment that they should be referred, at least just for the discussion. That goes along with the whole shared decision-making paradigm. Maybe Mary just wants to do a transplant now as she's going to be getting older. She wants to just get it out of the way, check it off her list of things to do. I had a transplant, and then go on with maintenance and other drugs. Now, a very common way of treating myeloma in this day and age is a 3-drug regimen. You'll see throughout this presentation, 3 drugs in myeloma are generally better than 2 drugs if you want a deeper response, getting the protein in the blood or urine down as low as possible. This study that was led by Dr. Brian Dury of the Southwest Oncology Group, the SWOG 777 study, compared 3 drugs, bortezomib, lenalidomide, and dexamethasone, versus just 2 pills, lenalidomide and dexamethasone. None of these patients had transplant. The group that had the 3 drugs only had about 6 to 8 cycles of the bortezomib before it was stopped, and then everybody just had len maintenance. The take-home point of this study is that the 3 drugs were better than 2 in keeping people in remission. We call that progression-free survival, the time that patients are in remission from starting a therapy to stopping the therapy. There was also a meta-analysis after transplant. Let's say Mary went on the transplant. We can't necessarily cure myeloma in many cases, but we can treat that clone and suppress it for as long as we can. There was a meta-analysis that was by Dr. McCarthy, looked at all the transplant studies. It showed a progression-free survival, longer remission when patients were on lenalidomide pills versus observation. So staying on medicine, just like a lot of other chronic conditions in medicine, like hypertension, diabetes, it's recommended to stay on therapy as long as possible. Now, what about if Mary doesn't want a transplant? There is information to support just staying on lenalidomide. We have a study called the FIRST trial, which was people that were non-transplant. Staying on lenalidomide kept them in remission longer. And there's a newer study that shows that there was, again, a progression-free survival benefit. People staying in remission longer when they stayed on lenalidomide. And it didn't matter the age or the risk groups, if they had high or low risk or what stage they were in, they still did better when they stayed on therapy. So that's important for nurses to encourage your patients to keep taking the medicine. And if they have side effects, then bring that to the attention of the healthcare provider. The final maintenance study I want to highlight to you is some new information, the Tourmaline MM3 study, which was using Activism. Now, this is a pill that's taken 3 times out of a month. That's it. So you think Monday, 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 then nothing. This showed that after transplant, just 3 pills a month led to what? A progression-free survival against people that didn't have it. So again, the key point in myeloma is to stay on therapy, to suppress the cancerous clones from forming so you can keep people in remission longer. Patients want to know if their treatment's working. Whether you're in the infusion center, in the outpatient, or the inpatient environment, it's important for nurses to be aware of how myeloma is monitored. Just simply, you have a protein in your blood. Educate patients as to where it is, or find out from their provider, where's my protein? Is it the blood or the urine? And then watch it go down. That's it. So if a patient comes in with too much protein like Mary, her light chains were high, we want to see that protein go down by 50% at least. That's your first remission point. That's your partial remission right here. The next remission point is the VGPR, very good partial remission, 90% reduction of protein in the blood or the urine. And then finally, in the blue areas are the deeper responses, such as complete remission. All the protein's gone, and if anybody didn't know any better, they didn't have myeloma. No protein in the blood or urine. Getting to something called minimal residual disease is really important. One of IMF's passion is prevention, and the other one is cure. And so we have lots of studies now that are trying to identify a cure. Think of it as an iceberg. The very tip of the iceberg are the blood tests that we have currently available. So here's your SSS patient, floating on the water. Hope they don't hit that iceberg. And then down here's the disease burden. We now have the ability with certain genetic tests to detect 1 in a million bone marrow plasma cells. Think about that. So in the blood and urine tests, we can only see so much, but now we have tests available to see that MRD negative status, or how deep a response from therapy they have. We have studies that support doing this that say the deeper the remission you have, the more PFS, progression-free survival. That's the theme of today, right? Keeping people in remission so they can live longer and enjoy their quality of life. Patients that were MRD negative or had 1 in a million bone marrow plasma cells had a PFS or survival of 92%, and that was better than if people had measurable disease. As I mentioned, MRD testing is commercially available. clonoSEQ is one of the tests that we use quite often. It might be available in your institution. It might be reimbursed by Medicare, but it only informs us as to the remission status. We still don't know if patients should stop therapy or remain on therapy. So it gives us information, but it doesn't change our treatment decision making.
So what you've seen is a huge alphabet soup. I mean, even for us to keep up on all the terminology, whether it's the disease monitoring, the medications, et cetera. It's a steep learning curve for not only us, but the newly diagnosed patients with multiple myeloma. Of course, explaining things verbally, but giving them a really reliable sources of written information that they can take back, that they can refer their friends and family to. The shock of diagnosis makes understanding it even more difficult. So some of the reliable websites I'm sure many of you are already aware of, the National Cancer Institute, the American Cancer Society, the Leukemia and Lymphoma Society, but of course the International Myeloma Foundation. So if you haven't gone to their website, I really would encourage you to, because it's not only good for patient and family teaching, it's a really good source for you if you like, oh, I sort of forgot what they were talking about at the conference, hopefully not. But they not only only have the website, they have teleconferences, they have all of these free brochures, and in multiple languages. Some of their core documents, like the introduction sort of to myeloma, has over like 21 languages, and that's the only organization really that I know that really is so multicultural, and so we're very proud of that. If a new medication is FDA approved, they're on it. It's on their website. So you can order these materials as well. You have an order form, or you can call up and you can get a packet sent for new patients, but also you can keep some in your clinic so that for like newly diagnosed patients, you can have information about basic lab tests, for example. So I'd really encourage you to look on the website if you haven't already. So part of our role, of course, is specific patient education as well. And as you saw, Mary presented with bone pain and lytic lesions, and that, of course, can be life-threatening. So 85% of patients develop bone disease, even if they don't present with it. And bone destruction can lead, of course, to the hypercalcemia, leading to, of course, renal problems, and spinal cord compression is an emergency. So patients really need to know, particularly if, again, they don't present with it, signs and symptoms of a new pain, bony pain, fractures, and that they have to get it worked up and addressed immediately. Our nursing implications are we need to make sure that patients are heard and that they're provided the imaging and treatments that they need, and educating patients on not only the symptoms of bone disease, but bone health, making sure that they keep up on their bisphosphonates, that they keep up on their exercise, for example. We're not going to talk too much today about that, but really maintaining their exercise, their bone health, et cetera. And then if the patients, particularly if they're admitted, do they have lytic lesions that require us to really take into account potential for fracture if we're helping the patients with mobility.
Now, Sandra just said a minute ago, we're not going to talk too much about exercise. I just want you to know that she is a fitness queen. So one of her passions is educating about the importance of health and physical activity, and that should still be recommended to all our patients.
Yes.
When they have damage to their bone from the myeloma lesions, they still can walk, they can still swim, they can do light weight-bearing exercises, and it's important to encourage that kind of physical activity. So you might not talk about it, but I wanted to put in a jab there for the importance of exercise and healthy living, because especially the first remission that Mary gets is going to be her longest one, the best quality of life. So we want her to embrace that as well. There are American Society of Clinical Oncology guidelines that recommend how we should protect bones in myeloma. There have been numerous recommendations over the years, but a bone-modifying agent is recommended for all patients receiving anti-myeloma therapy. All patients should have their bones protected. There are 3 major drugs. We call them bone-modifying agents. The first 2 are pamidronate and zoledronic acid. They've been around for years. They shouldn't be given to patients with renal failure or a creatinine clearance of less than 30. Therefore, now we have denosumab, a monoclonal antibody that is directed to attack rank ligand in the bone, and it does show there's an increased progression-free survival among patients in a non-inferiority study that took denosumab. The really important thing to remember about these drugs is that denosumab, you need to take calcium because you can get profound hypocalcemia. Think of your other disease states such as prostate or breast cancer. Their calcium can be severely low. So I recommend to take like 2 Tums once a day, especially around the days that they have the infusion, and make sure that you're looking for renal status as well. Encourage them to have good bone health and dental health also.
Another important aspect of education of our newly diagnosed myeloma patients is renal health, of course. So patients may not understand that, well, you don't have renal problems now, but active myeloma can at any time lead to renal problems. Of course, high calcium and other medical issues if the patient also has underlying diabetes, et cetera. What patients may not understand is they say, oh, I'm urinating fine, I don't have any renal problems, but decrease in urination is not always the presenting symptom of urine problems, as you know. They often can just start to be dizzy, a little bit lethargic. Some patients can actually have leaky kidneys where they're urinating a lot. So they need to understand how to, subtle symptoms, confusion, for example, we've all seen this, but also how to prevent it. So they should question anybody who orders a imaging study with IV contrast, and of course avoid nonsteroidal anti-inflammatories. When you tell the patient to hydrate, you need to explain exactly what that is. Is it 3 large bottles of water that they bring in, or how much is that? Patients don't understand. You need to be very specific. And then for treatment is, of course, correct the underlying cause, and treating the myeloma can actually help improve renal dysfunction, as it did in Mary, and using myeloma treatments that have a quick response really helps, again, preserve kidney function. So we want to do that as long as possible, because we have seen patients, of course, that end up on dialysis. Infection prevention is probably one of the most important things in terms of our patient education, because it can be the most life-threatening for our patients. So, of course, the myeloma has impacted the bone marrow. Patients may become neutropenic not only from the disease, but of course from their treatments. And then, as we know, myeloma cells don't make normal immunoglobulins, so of course these patients may get hypogammaglobulinemic, further increasing their risk of an infection. So as we know, the standard is good personal hygiene. The skin is a big part of our immune system, the biggest part really, as well as good frequent oral and good hygiene. Environmental controls, of course, washing hands, avoiding crowds of sick people, good food safety practices are the standard. Prompt medical attention at the signs of infection, so any mild fever, chills, even the subtle signs of infection. So these patients, again, might be only mildly neutropenic, but they may be slightly hypogammaglobulinemic, and they may be on steroids too, which can mask infections. So I always tell my patients, you need to sort of become a germaphobe and be very, very quick to jump to something. Nobody's going to blame you for calling for any subtle sign of infection. Medications may be prescribed prophylactically, so some practitioners, depending again on the patient's level of immune suppression, may be put on levofloxacin, as well as they may be on antifungals, antivirals. Growth factors may be prescribed to reduce the severity and duration of neutropenia, and as I mentioned, if they're hypogammaglobulinemic, they may get IVIG. Immunizations are very, very important. If they're 65 or older, they'll need the Pneumovax. They'll want the seasonal inactivated influenza. Some practitioners recommend a double dose. I don't know that that's the case this year, but I've seen some practitioners order 2 doses of the influenza vaccine, and then, of course, the shingles vaccine as well. So getting back to Mary, she worked with her treatment team to come up with a treatment decision that worked best for her. She even considered available trials, and she decided on a 3-drug induction regimen, bortezomib, lenalidomide, and dex, and the lenalidomide was dose adjusted for her renal impairment at the beginning. Supportive agents include, she decided on the denosumab or Prolia injection, plus the calcium supplement that Beth talked about. Nursing key points, of course, again, talking about kidney function, and she had very slight kidney dysfunction, but again, we want to maintain that kidney health and the bone health. She did receive the subcutaneous bortezomib, which reduces the likelihood of peripheral neuropathy. However, we want to make sure we educated her on the signs and symptoms of neuropathy so they occur. If they occur, we can treat them promptly and make sure she maintains her treatment schedule. Dexamethasone may be given at night and in the mornings, but it needs to be given the same time each day. And her potential for a DVT is fairly low, although a little bit she does have some risk due to the lenalidomide, so a baby aspirin was prescribed for VTE prophylaxis, and then as well as acyclovir prophylaxis. So if you talk to myeloma patients, usually steroids, we speak at some patient family seminars, and steroids are the bane of their existence. They hate them. Although some spouses like them because then the patient's cleaning up the entire house. It's great. They can sit back, watch TV. But anyway, again, the myeloma, the IMF has some fantastic information on understanding steroids. The important thing is steroids kill myeloma cells, and so that is really the mainstay of most of these therapies, a big part of therapy. Same as for like acute leukemia or lymphomas, are very, very important. And so we need to emphasize with our patients and families, don't stop or change the dose without discussing it with your provider. Some patients tolerate them better taking them in the morning, some tolerate them better taking them in the evening, but whatever, they should be taken with food. And then proactively manage side effects if they end up with some hyperglycemia problems, making sure they have a checklist or something that they can monitor when to take it, and the doses can be adjusted with our healthcare practitioner if they do have side effects that they really can't manage. So very important. So getting back to Mary, she achieved a very good partial response after 4 cycles, so that's good. Her kidney function improved. Her creatinine went from 2.1 to 1.2. She did collect her stem cells and ended up having an autologous stem cell transplant. A maintenance therapy was planned, and minimal residual disease testing was planned for 1 year. And so at this point, it's really important that we talk about a survivorship care plan. So many of our patients will go and will get a lot of their treatment maybe at a myeloma center and then go back to their community oncologist. And so we need to make sure that we liaise very closely with these other practitioners, but that we give all that information to Mary so that she can be aware of all of her diagnosis and treatments, the follow-up plan, coordinate with the primary care provider as well as her local oncologist, and go over her long-term risks as well as her survival care plan. So in terms of maintenance therapy, patients are on therapy for a long time, as we've talked about, and so part of our role is really making sure that we help them manage the side effects, that they adhere to their treatment, and that we consider adjusting it to make sure they tolerate it as best as possible. So lenalidomide maintenance is approved for after transplant, and you may see different schedules and dosing, but she was put on maintenance therapy. Short term, there can be some side effects, but there are also long-term effects of many of these therapies, so we need to make sure they continue with all of their health care screenings, their DEXA scan for bone density, their colonoscopies, their mammograms, all those things. You know, patients don't get a free rein on these other health-related screening. And then patient advocacy, understanding, again, the patient's changing needs and desires. Part of that shared decision-making, Joseph mentioned a patient, maybe they want to, you know, change up their treatment for a while because they want to be on an oral regimen so they can attend a wedding in another state or whatever it is. So really making sure that we work closely with our patients and make sure that our patients are heard along with the treatment team to make sure that they maintain their therapy.
So survivorship care plans are so important. In your handout, you have this sheet that the Nurse Leadership Board put together, and it has all those recommendations. It enables that communication between the local hematologist, oncologist, the primary care practitioner. We emphasize the importance of functional mobility and making sure that they continue to be active. And like Sandra said, they don't get a free pass on all their other health care conditions. There is an increased risk of secondary cancers, and it is important to make sure that they stay healthy, especially for the next treatment. So some myeloma patients, 17% will have what's called an operational cure. We are keeping them on medicine, but they're still in an excellent remission, and we don't even know what the new therapies are, how much longer they'll live in remission. The last 2 slides of this section will highlight the IMF's research initiatives. If you want to learn more about this, you can go to myeloma.org and learn about the Black Swan Initiative. Again, really stressing the importance of prevention of myeloma and cure of myeloma. MRD cure trials in smoldering myeloma, looking for MRD negativity in tests, and like the Black Swan, you thought it never existed till you saw one. We never thought a cure could be possible until we found some people are functionally cured. iStop is unique because it's examining blood samples from 140,000 adults over the age of 40 in Iceland, trying to identify and screen and monitor patients from that era. Unfortunately, most patients will not stay in remission forever. They'll go through these progression periods of remission and relapse until ultimately more clones will form that will have a hard time to manage. We're going to talk more about that, but now I'd like to invite Kim Noonan to share our last 2 case studies, Aaron and James. Thank you.
Good afternoon. So we saw that in the last case study, Mary was treated in the upfront setting. So our next two studies, case studies that we're going to talk about are Aaron and James, and they're both in the relapse setting. So here, first we have Aaron. He's a married, retired plumber, 68 years old. And he presented the usual way where people have pain, workup maybe with an SPEP, really led to that diagnosis of multiple myeloma. He has normal cytogenetics. What's interesting about Aaron is that he, right from the beginning, was bone marrow. He was ineligible for transplant because of pulmonary hypertension. He also has past medical history of diabetes, as well as the fact that he's an ex-smoker. So he was treated with BRD, much like Mary, and then put on maintenance lenalidomide, as Beth spoke about. And you know what? He did pretty well for a little while, until December of 2018 when he was noted to have a biochemical relapse. And so if you look on your right-hand side, if you look at that, the flow sheet data, right at the very beginning, had about 5 grams of M protein, and he came down, and we really didn't hear from that disease for a little while. And then he slowly creeped up over 2.5 years. So, you have to work this up. He didn't really have any other symptoms. His lab values were normal. We looked at a low-dose whole-body CAT scan, and there were no new lesions. So that sort of brings us to the question of, was he symptomatic or was he asymptomatic? And we can see, you can read what symptomatic is all about, and we'll talk about that later, but asymptomatic biochemical relapses, you have this rising M protein in the setting of, maybe, no other symptoms. You work it up, you look at SPEPs, and you don't really have anything else to work with. So you sort of say to yourself, we need to, at some point we're going to have to treat this guy. When is that going to happen? And do we do it now or do we wait until later? Often you might see a little bit of a waxing and waning of M spikes. They can come and they can go, and it kind of can trick you. So the relapse workup is similar to the workup that we did initially when people are first diagnosed, but we're going to look at the serum protein electrophoresis as well as the urine protein electrophoresis. And certainly we're going to follow the CBC to make sure that this patient isn't becoming more anemic, right? And we're going to think about chemistries. What's his renal function looking like? And then look at the kappa lambda light chains and the M protein that we talked about. So we could consider doing a bone marrow. I recently did a bone marrow on a patient that had a little bit of an M spike. And to my surprise, he had 90% cellularity with plasma cells. So they can trick you. These myeloma patients can trick you. You want to also follow this with imaging. If you haven't done a low-dose CAT scan in a while, maybe you want to repeat that. If somebody like Aaron, 2.5 years ago, presented with a little bit of an M spike, you sort of want to follow that over time.
As Dr. Noonan mentioned, there are many different ways that patients will progress. They might look like there's not a lot of protein, but if they're not feeling right, use your nursing gut and tell the provider, or encourage the patient to let their provider know they're just not feeling well. Maybe additional workup is necessary. You've seen these buffet of treatment options, which are listed on the left-hand side. Again, we have these drug classes. It's amazing. And in this day and age, we have the IMiDs, lenalidomide, pomalidomide. Thalidomide's not in there, but I still use a lot of that to treat myeloma. And then they have proteasome inhibitors, bortezomib, carfilzomib, ixazomib. Then you have your monoclonals, elotuzumab, daratumumab. And then the other ones, HDAC inhibitor, panobinostats, also FDA approved, cyclophosphamide, bendamustine, doxorubicin, lots of options. So how in the world do you help your patient navigate this? This is what we're going to talk about now. There's a practical approach to treatment that many of us take at our institutions. Again, it's like that Venn diagram with the circles we looked at before. You take your data from the clinical trials, the clinician experience, the patient experience. How did they do with the drug in that same class before? Did they get a horrible rash from an IMiD, or did they get any other neuropathy from another agent? So you take into the patient preference as well as that. So how is their other health factors doing? Did they develop a heart disease, stroke, or other conditions? Do they have to attend a wedding, or do they have family that lives out of town? So again, all of these disease and treatment-related factors are considered. So with these new agents, some patients achieve deeper responses. So the prior two graphs we looked at how patients will ultimately become refractory to treatments as the clones will change over time. Now I'm pleased to report that some people will get their deeper remissions early on after the second or third therapy if we find the right recipe to control the myeloma disease in their body. But you still have an overproduction of a clone. That clone that was able to survive the transplant, or the clone that was able to survive the prior 5 lines of therapy, can be a very resistant clone. Why? The immune system is meant to protect you from getting sick, and now it's just goofy, dysfunctional, making all these clones. So one of the things that we think about is the way to better use the drugs we have available. This study looked at the doses of dexamethasone and how it improved the event-free survival. 2010, we had a study by Dr. Raj Kumar with lenalidomide and high versus low-dose dexamethasone, and now we have this study with the RD continuous and lower doses of the effective agents. And what it's shown is that less was more in some patients. They had better progression-free survival. Frailty scores are very important in many hematologic and solid tumor malignancies these days, and we have a myeloma frailty score calculator.net you can access. We have some other information in our appendix slides. Basically, you want to calculate how fit the patient is with a score of 0, 1, or greater than 2, and it informs us to the correct doses. So if your patient has a very frail, you might want to do something called RVD light, which is lenalidomide, bortezomib, dexamethasone, but in reduced doses to address that frailty of that patient, to reduce the chance of treatment discontinuation.
All right, so back to Aaron. You know, we heard Joseph talk about shared decision-making, and certainly we want to consider what is important to Aaron as well as his family, as well as his providers. And so also entered into this, he lives close to the clinic, right? So it's not somebody who's going to be coming from, you know, the other side of the country. So that, I think that's extremely helpful. He's progressing on lenalidomide maintenance, and so the question here is when are we going to treat him, not, you know, not if. And he also has peripheral neuropathy. We saw before that he received IV bortezomib, which really has an increased incidence of peripheral neuropathy. So Aaron and the healthcare team decide that they prefer a combination, that really is, he's going to achieve a better outcome with that. So with that, we sort of think about pomalidomide. Pomalidomide is an IMiD that, in people that are refractory to lenalidomide, this is really a very good choice. It's an oral IMiD, and it's important to monitor counts when people are on pomalidomide. Neutropenia is the most common grade 3, 4 AE, and other common side effects include GI toxicities, constipation, diarrhea, VTEs too, so you really want to think about prophylaxis with anticoagulant, and fatigue with this group. And so you want to think about how we're going to manage these side effects. Certainly, we want to manage the individual side effect, but we want to consider perhaps lowering the dose of pomalidomide because people are going to tolerate it better. That really is what we're after, you know, sort of what is the best treatment for you and what is the best quality of life that we can offer you while you're on this treatment. So, so we decided that's, you know, what we're going to treat him with, but what are we going to put it with? Because we decided that combination therapy would give Aaron the best outcome. So would we treat him with a monoclonal antibody? And perhaps we would. And so we have two options with monoclonal antibodies. One is elotuzumab, and the other one is daratumumab. And so I don't think you can have dessert until you can say elotuzumab and daratumumab 15 times without messing up. And if I do it, then even better, right? So anyway, elotuzumab targets SLAMF7. Anybody here say, what the heck is a SLAMF7? It's a signaling lymphocyte activation molecule family, and specifically, this is that protein 7. So about 10% of everybody that receives elotuzumab or ELO is going to experience an infusion-related side effect despite really giving pre-meds, and similar to most monoclonal antibodies, we're going to pre-treat people with dexamethasone. We give dexamethasone 3 hours to 24 hours before we infuse elotuzumab, and believe me, we really hold that standard. We have patients that forget to take their dexamethasone, and now it's, you know, 10 o'clock, and I know they're not going to treat them until 1. So we're pretty serious about the pre-treatment with dexamethasone before we give elotuzumab. The way that it's given weekly for 8 weeks, and then it's given every other week. So you want to monitor and make sure you look at blood counts, and you're going to hold it if it's low. You're going to think about VTE prophylaxis when people are on pomalidomide, as well as if this drug is going to be used with lenalidomide. You also want to monitor dexamethasone. You want to monitor glucose because we know that Aaron is a diabetic. So you want to make sure that he's doing okay with that. Renal, hepatic, paying attention to the renal and hepatic status is very important. And you want to assess for response, which I think we're going to talk about more in the next slide.
Absolutely, and as Kim mentioned, that 3-hour window, especially when they're starting treatment, is important. Oftentimes, if I trust my patient, which I try to trust everybody, right? But there's some people that just can't sit in a chair while the pre-med works, so we have them take it at home 3 hours ahead of time. And eventually, if they've taken the elotuzumab for a while, they can just start taking it without actually the steroids over time. But this study highlights on here, this was a phase 2 study with elotuzumab, pomalidomide, and dexamethasone, EPD. This was a phase 2 study. Everybody got the treatment, and what it showed is that patients had a very good remission status when they had the drugs combined together. The thing about the elotuzumab in this study is that they went weekly for 8 weeks and then monthly, which is different from elo combined with lenalidomide dex, which is every other week forever, pretty much. So it's important to know the different dose schedule and why your patient's getting what. There are special considerations with antibody therapy. As Kim mentioned before, we worry about a lot of different interferences. There is a potential interference with lab tests. So this myeloma is an abnormal clone, and oftentimes it's IgG kappa or IgG lambda. And if you have a spike in the blood, it might just be the elotuzumab or daratumumab, which we'll be speaking about in a moment. And so it's important to reassure patients who are looking at their lab tests and assessing for response and say, oh, I didn't get rid of this M spike in my blood. It might actually just be the medication. No laboratory assays are in development but are not ready for prime time yet in most labs. Daratumumab is a monoclonal antibody directed to CD38. CD38 is loosely linked to red blood cells, but it's also a cell surface marker for myeloma cells. And through the 4 mechanisms of immunomodulatory effectiveness, like antibody-dependent cellular mediated toxicity, et cetera, you block that CD38, and then the myeloma cells die.
A little bit more
Hopefully, they die.
Right. A little bit more about daratumumab. So as you can see that it was initially approved with 3 prior therapies back in 2015, and that was for monotherapy. And then it sort of moved up for two prior therapies in 2017 with pomalidomide and dexamethasone. And I think it was, in 2016, it was 1 prior with lenalidomide and dex, as well as with bortezomib and dexamethasone. And I think it's very exciting that last year, VMP plus DARA was approved for first-line, non-eligible FDA, non-eligible transplant patients. So it's really moving. I think really the message here is keep looking out, because we're going to be using daratumumab in a lot of different ways, and probably more often in the upfront setting. So a couple of things to consider with daratumumab. So the patient is sort of going to come in, and that first day, that infusion is going to be lengthy for them. And so to say to them, today it's going to be lengthy, maybe 8 hours, maybe 10 hours if there's an infusion-related reaction, which about 45% have during their first infusion only. But over time, we're going to be able to increase the time that we're able to give daratumumab. We pre-med people, as we do with most monoclonal antibodies, with corticosteroids, antipyretics, antihistamines, and patients are asked to take steroids for either 1 or 2 days, depending upon the steroid that we use. Often, we're able to get rid of the steroids after the first cycle of daratumumab. The herpes prophylaxis is very important, too, with people that are receiving daratumumab.
And I think we also mentioned the interference before and the type and cross-match issues. Again, the CD38 is loosely on the red blood cells, so if your patient is at risk for needing a blood cell transfusion, you need to get a baseline type and screen and then follow that up and alert the blood bank. So you should have your standard of care in your institution. Find out what that is if you have patients that are receiving daratumumab. These are 2 studies highlighted on this slide. Again, we see all these mixing and matching of classes of drugs, the IMiDs, the proteasome inhibitors, monoclonals, and the cool thing about that is that you can get various response rates and you can monitor for the side effects. So to the left, you have the CASTOR clinical trial, and that was combining DVD, darabortezomib dex, versus bortezomib dex. And you can see in this study, we had a longer progression-free survival. People stayed in remission with the 3 drugs more so than the 2 drugs, bortezomib dex. So the next study is the POLLUX clinical trial, which is the DARA lenalidomide dex versus Lendex. And then you can see the better progression-free survival, the benefit at 24 months of those that had the 3 versus the 2 drugs. Now, because we love acronyms in myeloma, we have another regimen, pomalidomide, dexamethasone. We heard about the clinical pearls from Kim when she was talking about pomalidomide. It's an oral agent that's used, an imminent agent, and we saw in this study that there was an improved progression-free survival in people that had more than 2 therapies. They still went into a good remission. Remember, we talked about response and remission, that partial response is 50%, then the VGPR is a 90% reduction in proteins. That's what this slide is showing here. So you get pretty deep remissions even if people have been on prior therapies, which is excellent news. These 2 ways of giving daratumumab are currently under investigation. The one to the left shows a 90-minute infusion of daratumumab via rapid infusion, and this is great for our patients. After the first 2 infusions, if they haven't had a very serious infusion reaction, we can speed it up to 90 minutes, and that's our standard of care at our clinic and Cleveland Clinic in Ohio, as well as the Dana-Farber and many other institutions. It's been shown to be safe and effective. Remember, when drugs are studied, we want to find if they're effective. Then later on, we find better ways of infusing or administering them, and that's why now, after the 2015 approval, we're learning that it is safe. Subcutaneous daratumumab continues to be in clinical investigation. It's not commercially available. Many centers around the country are studying it for myeloma and other plasma cell-related disorders, and there seem to be no new safety signals, so hopefully subcutaneous will be available in the future. Here's a phase 3 study of the DRD versus RD, dara, lenalidomide, and dexamethasone versus 2 pills, LD, lenalidomide, dex. So what do you think I'm going to say about this study? Better progression-free survival of the 3 drugs versus the 2 drugs, right? So patients 71% versus 56% in remission, a 44% reduction in the risk of progression or death. And these are newly diagnosed patients. So as Dr. Noonan mentioned, we're going to be moving this earlier on in the treatment paradigm, this daratumumab agent, in many cases.
All right, so we'll go back to Aaron. And so after 3 months on daratumumab, pomalidomide, and dexamethasone, he is tolerating therapy very well. His glucose is under very good control, as his calcium, creatinine are all really very well under good control as well. And so we hope that he can stay on this therapy for at least another, 20, 30 years, right? That's our goal. That's absolutely our goal. So as we've been talking about, it's really important to look and update the survivorship care plan. He really needs to know what tests we're following. Is it, his free light chains? Is it the M protein? What are we following? And what current doses of therapy is he on? Pomalidomide, did we have to lower that a little bit? And then to review, to talk about what the PCP is going to handle, the well baby care, who's going to do the PSA, are we going to manage the vaccinations back where we are? So it's really, I think, important to set up ownership of that. And again, with health promotion, that Sandra wasn't going to spend too much time talking about. Diet, exercise,
Which
lifestyle.
keeps coming back.
Don't smoke, and really don't drink too much. Support groups are essential, and for somebody like Aaron. So we're going to wrap Aaron up, and we're going to move to James. And James is a 63-year-old who is a widowed store manager, helps with his 2 daughters financially, diagnosed in 2013. And he, like the other 2, was treated with BRD, but a little bit different. He did receive a stem cell transplant, and that was followed by 2 years of lenalidomide. And so he did well until 2018 when he presented with leg pain. A skeletal survey reported new femur lesions as well as rib lesions. And so we see that, when we're thinking about what kinds of treatment options we have for James, and by the way, he has plenty of treatment options, I was becoming exhausted when that litany of options was discussed by Beth. I mean, there's so many options.
Me too.
For James, right? She was almost, I was out of breath for Beth. And so you need to, the fact that he doesn't have a cardiac history, the fact that he lives near the clinic, these are all going to enter into the shared decision-making. And so the 2 options that were discussed is maybe IRD and KRD, which we're going to talk about in the next few slides. But we also have to think about the fact that James is symptomatic, right? So look at those symptoms. He is somebody that came in with worsening pain. He has an increase in his creatinine. He also had an increase in calcium. So we're really stuck. We really have to treat James. All right, and so one choice that we talked about would be IRD, which is an all-oral regimen, ixazomib, lenalidomide, and dexamethasone. I'll repeat that again because I think there was a question on this, right? It might have been, I don't know, but it's an
Leading the witness, Kim.
It's an all-oral regimen, right? And it was approved in 2015, and so it's approved for patients who have received one prior therapy. Ixazomib is administered weekly, days 1, 8, and 15 on a 28-day schedule. It's taken on an empty stomach 1 hour before and 2 hour before or 2 hours after food. And so some of the things you need to think about, and we've been talking about this, is really oral adherence, right, to their medication, but also cyclical sort of thrombocytopenia. People can develop peripheral neuropathy on ixazomib. Peripheral edema, nausea, too, is common for patients that receive ixazomib.
And this is an example of a calendar. So many nurses are charged with helping patients adhere to their treatment, and calendars and reminders, electronic reminders, are some of the most important things. Remember, we said ixazomib is just 3 pills a month. So I take an orange highlighter, just like this slide, and I do orange, orange, orange. I ask the patients what day of the week you want to start, and we fill that in. Then the lenalidomide tends to be 25 milligrams starting dose. Remember, we dose reduce ixazomib for hepatic or kidney disease to 3 milligrams if severe. Lenalidomide dose reduce for kidney disease. And then dexamethasone, we can dose reduce for frailty, 20 to 40 milligrams weekly. So find out what the correct regimen is and help your patients learn how to make their own calendars so that they can adhere to treatment better, and then they don't have to keep calling you and you don't have to keep making the calendars yourself. They're really taking ownership of their illness. We talked about the IRD, ixazomib, lenalidomide, and dex. This was a study of 722 patients that was reported a couple years ago. It was an international study which showed that there was a progression-free survival in patients who had at least one therapy or more of 20.6 months when they took the 3 drugs, IRD, pills, you take it home, versus placebo. Again, there's monitoring. There's baby aspirin for the lenalidomide. There's shingles prevention with the ixazomib, but it is something that can really work for their lifestyle in many cases. Kim?
Okay, and so another option for James would be carfilzomib, lenalidomide, and dexamethasone. And so carfilzomib, as you can see on the right-hand side, has many doses, right? So we give carfilzomib 20 milligrams per meter squared for the first cycle, and then we increase the dose, and whether that's going to be 27, 56, or 70, which is the weekly dosing of carfilzomib, is really up to really how the patient's tolerating it, as well as the goals of therapy. And so, for some of the clinical pearls that we need to think about with carfilzomib is that the patients should be hydrated when they receive carfilzomib, but not overhydrated. You really need a good understanding of the patient's cardiac and pulmonary status, and you need to optimize their cardiac issues with diuretics, for example, as well as maybe inhalers for pulmonary issues. Aspirin should be used for thrombosis prophylaxis, as well as herpes prophylaxis should be used. You need to monitor counts, and I think that infection control and infection reporting is extremely important with this, because people really can become very infected quickly, and we really need to, people have great outcomes if it's reported and, we act on it quickly. But think about, thrombocytopenia is often seen in people that are receiving carfilzomib, anemia as well, and fatigue. Really, I think overwhelming fatigue is what I often hear patients describe. However, this drug in combination with other agents is an excellent choice for somebody like James as well.
And it's important if your patient is telling you, and you're an infusion nurse, or you're in the inpatient, encourage your patient to speak up to the provider, because we can provide dose reductions and modifications for fatigue, for thrombocytopenia, and we can take planned treatment holidays in many cases to improve their quality of life. Drugs don't work if people don't take them. I didn't say that C. Everett Koop did, but we want to try to keep our patients on therapy, because as I've demonstrated through these case studies, staying on therapy is better than stopping therapy no matter what you're on. This particular study investigated 2 different dose levels of carfilzomib, once weekly 70 milligrams per meter squared IV versus twice weekly 27 milligrams per meter squared. In myeloma, for all doses, we do a ramp up starting at 20, so don't forget to tell your patients because they'll think it's not working. If you increase the dose the next week, they'll call you from the infusion center. But in terms of the response rate, these patients did not have any significant increase in toxicity, but they responded better at that higher weekly dose, which goes against what we used to be doing in terms of the carfilzomib.
Okay, and so back to James, and when you look at the fact that IRD was selected, was there ever a doubt that he wasn't going to choose the all-oral regimen, right? Considering, having to come to the clinic on a pretty regular basis. So he selected IRD in combination with his providers. And after 4 cycles, he achieved a VGPR, and he's tolerating treatment well, and he likes his all-oral regimen and the convenience of not having to come to the clinic that often.
There are many other drugs or regimens in development, and I'm pleased to show you that there are immuno-oncology approaches, which we'll talk about in a moment, other approved drugs for other indications, such as venetoclax, an oral drug approved for CLL, as well as ibrutinib, which has been studied, and then selinexor. Again, we're investigating better combinations, sequencing of drugs as well. I'd like to highlight for a moment selinexor. This is a very unique drug. It's a selective first-in-class oral inhibitor of nuclear export, or SINE compound. So we have the MIBs, the MABs, the MIDES, and now we're going to have the SINEs. Just kind of made that up, but it's actually been to the orphan drug designation for FDA and fast track designation by FDA. How does this work? Well, the selinexor is a covalent oral selective inhibitor of this XPO1 protein. It blocks the tumor suppressor genes from being exported from the nucleus. We need the tumor suppressor genes there so they can kill the myeloma cells. So it blocks it from leaving the nucleus so you can kill more cells. The selinexor had a STORM clinical trial. There was a 26.2% overall response rate. We know that when patients fail bortezomib or pomalidomide or IMiDs, they confer a poor prognosis, short survival. So this is a newer class of drugs that can potentially give them a 26.2% response rate. Most of the patients had 7 prior treatments, and many of them were refractory, what we call pentarefractory, where nothing else was working with them. We had stringent CRs seen in this study, as well as a median overall survival of about 8.6 months. The important thing for you to remember as a nurse who's hearing about selinexor for the first time is that when it comes to market, you're going to be critical to helping with side effect management. This drug is effective, but there can be some side effects such as fatigue, thrombocytopenia, weight loss, and other things which can be very effectively managed by nurses if we work with our patients. There are no significant major organ toxicities in prior clinical studies or bleeding or infection rates, but it's still something that needs to be monitored. We have new ways to target and kill therapy, CAR T-cell therapy. You know about that from lymphoma. We'll talk about that in a moment. BiTE antibodies, bispecific T-cells engagers. We're engaging the T-cells to fight the myeloma cells. And then finally, drug antibody conjugates. So such an exciting time of myeloma in 2019. Briefly, I want to share the CAR T-cell clinical trial in myeloma. I'm very excited to report that, remember, we get some of our deepest remissions after prior therapies. The BB2121 is a second-generation CAR T-cell therapy. It targets the CD269, and it's a phase 1 clinical trial. And of these 43 patients, many with prior therapies, you still had deep and durable responses. And they get the cellular therapy, and then you just observe them. And so it's very active dose, had a median progression-free survival of 11.8 months, again in a group of patients that had a lot of prior therapies. Kim?
Okay, and so in finishing up, before we get to the questions, right? So as you can see from today's discussion, there are so many options for multiple myeloma patients, especially over the last decade. There's just so many to consider. But what we do need to consider is how we're going to educate ourselves, our patients, about when we're going to use these, how we're going to use these, look at the different schedules that we're using these drugs on. So nursing is absolutely the key to all of this. And so patients rely on your guidance and your expertise in providing the quality care that they deserve.
So let's do the last few questions. I know you know all the answers, right? Which of the following is used for the diagnosis of myeloma-related organ dysfunction? Fish, MGUS, salt, or crab? I hope you didn't misplace your ARS. I love to see the post-test, and we'll show you what your responses were when they stopped the music. 80.3%, great, much better. Next one. Which element is essential to foster shared decision-making? Greet your patient. Seek your patient's participation, sharing information by both parties, or building consensus about preferred treatment by both parties.
100% here. We're going to get 100% here.
So, it's so confusing though. For me, and I just listened to the lecture. This is confusing. Let's see how you did. Building consensus. Wasn't it number 2, Joseph? Yeah, seek your patient participation. After all that, they forgot. Remember, the most important thing, seek your patient participation. Invite them to participate. Seek their participation. But you know what? That's why I said it was confusing. I would have picked 4, too.
I would have gotten that wrong. Yeah.
Come back next. Which of the following
All
is
of the
true
above.
about newly diagnosed patients with myeloma? All should be tested for MRD as soon as possible. Shared decision-making is only effective if the doctor and patient discuss. All patients need to be educated on many topics, including bone, renal, health, and infection, and bone strengthening agents are only recommended for bone damage. Why do these seem harder this year? Who wrote these? We did, by the way. The correct answer is 3. Yay!
Excellent.
Oh, that's awesome. Good for you guys. And then finally, which of the following is an all-oral regimen for relapsed myeloma? KRD, IRD, EPD, or DPD? And the correct answer is, yay, IRD. You all did an amazing
Very
job,
good.
and thank you so much for sharing our stories of our patients. We'll be here for question and answer.